Hey there. My name is Matthew Smith. I am the Assistant Paramedic Program Coordinator at LaGuardia Community College at CUNY. I am the Training Officer for Ridgewood Volunteer Ambulance Corps. And I had somebody write into me with a question that I thought was a really good question and deserved an actual video responding to it because I think a lot of people have some confusion about this, and I think I can bring a little bit of clarity to it. I hope. My background, I am a New York City paramedic. I'm also a certified flight paramedic. I come at this with the amount of understanding that a board certified paramedic has. I'm not a physician, not a cardiologist, so this is going to be somewhat rudimentary, but it's definitely going to be enough where if you're a paramedic, it's going to give you the degree of understanding that I think you need to have in order to function in that role well. So the question was, I was wondering if you would mind explaining in depth which medication is preferred for cardiac arrest or VTAC with a pulse. I know amiodarone has a very long duration and is metabolized by the liver, which can cause its own set of issues, but which would we prefer to use and why? And then the second question that was asked is also for AFib and SVT, is it better to use amiodarone or diltiazem as a medical control option? So these are excellent, excellent questions, important questions to be thinking about. Uh, we got to look at them separately because there's different issues involved in each. So let's look at each in turn. Amiodarone and lidocaine, when we use them to treat ventricular arrhythmias, what we're really after there is their sodium channel blockade. They're both sodium channel blockers. Uh, so lidocaine is pretty much just a sodium channel blocker. So if we look at what lidocaine does, and you'll always see this sort of graph of the cardiac action potential, and it's not super important that you understand the details of what's going on, except uh, that you need to know that when the heart depolarizes, it depolarizes because sodium rushes into heart muscle cells. That is the important thing to understand. Sodium rushes in, and that causes the switch in the electric potential of heart cells. So if we make it more difficult for sodium to rush into heart muscle cells, we make it less likely for those cells to depolarize. And the mental model you need to have for VTAC and VFib is that you have too much depolarization taking place. The depolarization switch threshold is set too low, and so you have ventricular cells that are firing off and depolarizing before we want them to, right? We want them to depolarize in response to an impulse that comes from the SA node through the AV node and down the Purkinje system. We do not want them to be firing off on their own because they think it's time to go. So the way that we can sort of suppress those impulses that those ventricular cells have to depolarize on their own is to block off sodium channels. And again, the reason for that is because it's the sodium rushing into the cell that causes the heart muscle cell to depolarize. So when we block off those sodium channels, we make it harder for the sodium to get in and initiate that depolarization. Both lidocaine and amiodarone have sodium channel blocking properties. Now, the way lidocaine works is it changes the sort of ramp of it changes the speed that the sodium will rush in. So it makes the sodium go in a little bit slower, but it does not affect the overall time of the cardiac action potential. In fact, it's normally when we block sodium, right, we make it harder for sodium to move. Normally that it would increase the total amount of time of the action potential. In the case of lidocaine, it doesn't increase it. In fact, it decreases it a little bit. And that's what you see here on this graph to my right, as you see it. Lidocaine will make it harder for sodium to rush into the cell, and it will do so in a way that does not prolong the overall cardiac action potential. And that's what you need to know. The other thing you need to know about lidocaine is its effects are quite specific to those sodium channels. It does not have other collateral effects on the heart to a great degree. Now, you're going to contrast that with amiodarone, where amiodarone has all kinds of other effects on the heart. So in addition to sodium channel blockade, and you can see it does the same thing to the sodium channels that lidocaine did, right? You see how the slope of this has now moved other way, right? Has moved this way. And you can see lidocaine did that same thing to the slope of that line. But in addition to that, amiodarone also blocks calcium channels and it blocks potassium channels. I'm sorry, in addition to doing what lidocaine does, amiodarone blocks calcium channels and potassium channels. And with those other effects, amiodarone prolongs the overall cardiac action potential. And that we see on the EKG as the QT, right? The time from depolarization starting is the Q wave. The time from depolarization ending is the T wave. That whole thing is the QT interval. So amiodarone prolongs the QT interval. It blocks sodium channels. It does make it less likely for heart muscle cells to depolarize prematurely, but it does so in a way that also prolongs the overall action potential of the heart, whereas lidocaine does so in a way that does not prolong the overall action potential of the heart. Now, all of this is theoretical, right? And when we talk about, because your question was, which would we prefer to use and why? And so in terms of which we would prefer to use, there's this concept called evidence-based medicine. And the idea of evidence-based medicine is we try different things and we see which one works better. And at this point, as between amiodarone and lidocaine, there is no preference. We have an equal weight of evidence on both sides that they work for cardiac arrest with a shockable arrest rhythm. So pulseless VTAC or VFib, they're equally effective. By the way, the efficacy, not that great. So although they're equally effective, it's not a great effect either way, but according to the folks that make our guidelines, it is enough of an effect that it's worth doing. So we do use amiodarone, we do use lidocaine, and you can choose either in the cardiac arrest context. Now, that's the general rule, is that there is no preference in cardiac arrest for either amiodarone or lidocaine. That having been said, more specifically, there are specific times when you can't use amiodarone. And those specific times have to do with what it does to the overall cardiac action potential. So remember, amiodarone prolongs the cardiac action potential. It lengthens the QT interval. So there's a specific time when we do not want to do that. And hopefully you'll recall that a specific type of VTAC, torsades, is caused by a critically prolonged QT interval. And so if you're treating a patient in torsades, you cannot use amiodarone because it prolongs that QT interval and will, in a sense, push them further into torsades. So for that patient, if you're going to use a sodium channel blocker, the only one you can use is lidocaine. However, if they're in persistent torsades, the best drug to use for that is actually magnesium, because magnesium shortens the QT interval. It doesn't cause sodium channel blockade, but it shortens the QT interval, and if that's the only problem you have, it's going to be fine. If you have a sodium channel problem as well, if you're back and forth between VFib and torsades, say, then lidocaine would be your drug to go with. Because it will help the sodium channel problem you have without lengthening the overall QT interval. So basically, the answer to your question is, for patients in cardiac arrest, is that you can use either, except if it's polymorphic VTAC torsades, and in that case you can only use lidocaine, but really you should use MAG. Okay, so then VTAC with a pulse is a little bit different. With VTAC with a pulse, there is no preference as to lidocaine or amiodarone. Uh, uh, according to the American Heart Association, which is the folks that make our guidelines, right? So the American Heart Association says lidocaine and amiodarone are equally effective. They're Class 2C recommendations for VTAC with a pulse. However, there is a drug that's recommended over both of them, a Class 2B recommendation, and that drug is a drug called procainamide. And procainamide, again, evidence-based medicine. There is a study out there that looked at procainamide, lidocaine, and amiodarone, and it found that procainamide converted these stable VTAC with a pulses more often with fewer adverse events than either lidocaine or amiodarone. So procainamide is actually the drug of choice compared to those two. Now, why don't we use procainamide pre-hospitally? Well, the reason has to do with the sort of pharmacokinetics of procainamide. It takes a full hour to get it up to a therapeutic level, so it's just too slow acting for us to use it pre-hospitally effectively. It's reserved for our in-hospital colleagues. But you should know it is the preferred drug there. Of course, the other thing to keep in mind with VTAC with a pulse is that you're really only treating with a sodium channel blocker if you've tried quite a few other things, and hopefully if you're being very thoughtful about it. So remember, first of all, that there are VTACs with a pulse that will respond to adenosine. They're called ventricular outflow tract VTACs. As well, you might not be looking at VTAC if you think it's VTAC. You might be looking at SVT with aberrancy. And that, of course, would be responsive to adenosine as well. So the first thing you should be trying is a vagal maneuver or adenosine if you have stable, what you think is stable VTAC with a pulse, right? You work from least invasive to most invasive. So the first thing to try, vagal maneuver. That doesn't work, go with adenosine. And then if that doesn't work, you should be thinking hard about what you want to do next. So yes, a sodium channel blocker is an option. Lidocaine and amiodarone are options, but it's also an option to put the patient on the stretcher and drive to the hospital. And if they're truly stable, that might be the best thing. The other thing to keep in mind is there may be some underlying causes, toxicological or metabolic causes that can cause wide complex tachycardias that are not ventricular in origin. And if you have those and you give a sodium channel blocker, you can kill your patient. So, important to understand that, and important to be very thoughtful about giving a sodium channel blocker to these patients. If you want to know more about that, there's a great video called How to Avoid a Clean Kill with ACLS from a doctor by the name of Amal Mattu, and I recommend looking up and watching that video. Highly recommended on why to be thoughtful about sodium channel blockers and wide complex tachycardia. Okay, so that's the answer to your question. In cardiac arrest, there is no official preference, except with torsades where you can't use amiodarone. If they have a wide complex tachycardia with a pulse, we'll start with a vagal maneuver. We'll try adenosine. If those don't work, we could give lidocaine, we could give amiodarone, but really the best thing is procainamide, which we don't have. And the lidocaine and the amiodarone can have some pretty negative side effects, i.e. death. So we want to be very thoughtful about using those before we use them, and err on the side, I think, of not using them. Okay, so then the next question you had is, for AFib and SVT, is it better to use amiodarone or diltiazem as a medical control option? So let's look at AFib and SVT. So we have AFib with RVR, we have this storm of atrial activity. When we have SVT, we have a reentry loop somewhere. SVT is an umbrella term, but generally when we talk about SVT, we're talking about a reentry tachycardia. So when I say SVT, and when you say SVT, I'm assuming you mean a reentry tachycardia. So that's what I'm going to deal with. So we talk about SVT, we have these reentry loops in the in and around the AV node, right? So diltiazem works by decreasing the transmission we get of impulses through the AV node and decreasing the conduction through the AV node, both of which will have the effect of decreasing the amount of impulses per minute that get transmitted down the Purkinje system and depolarize the ventricles, right? That is what diltiazem does in theory. So the mental model you should have of the AV node is that it's made up of calcium channels, and so diltiazem is a calcium channel blocker. And by blocking off those calcium channels, it slows conduction through the AV node, decreases impulses per minute through that AV node, decreases the velocity of conduction through that AV node, and by doing that, it decreases the ventricular rate, which is really what we're after. There is a side effect to consider here, and that's that calcium channel blockers will also dilate your vasculature. So do keep that in mind. Diltiazem will cause a vasodilatory effect, and so if you have a patient with a borderline blood pressure, you need to be careful. Okay. Amiodarone is also a calcium channel blocker that can work in exactly the same way as diltiazem, but remember that amiodarone is a very blunt instrument and it has all kinds of effects. So one of the other effects that it has is it's a beta blocker. So in addition to being a calcium channel blocker, it's a beta blocker. So if you have AFib with RVR, if you have SVT, amiodarone would decrease the intensity of that atrial storm that makes up AFib RVR, and so not only does it decrease the velocity of conduction through the AV node and decrease the impulses per minute that the AV node transmits, it also decreases the intensity of the atrial impulses that are giving rise to the impulses going through the AV node. And so it sort of works at the beginning and in the middle. For SVT, the beta blockade for a reentry SVT really I don't think would matter very much. It's primarily the calcium channel blockade that you're after to try to get the impulses to jump out of that reentry loop. As between amiodarone and DILT for these rhythms, either can be effective. The thing about amiodarone, other than the fact that it's a very blunt instrument, is that it has a lot of side effects. It has a very long half-life, and it can cause pulmonary fibrosis, it can cause thyroid issues, it can cause a wide variety of potential problems in the heart. And for that reason, I would want to be very cautious. If this were me, my choice would be to get diltiazem rather than amiodarone. Because I would be very concerned about the side effects that amiodarone can cause. That said, anybody who's getting either of these drugs is a very sick person and needs to be treated, and so it's a risk versus benefit thing, risk versus benefit analysis. My personal opinion is that diltiazem gives you most of the benefit with less of the risk, but that's my personal opinion, and I do not have an MD after my name, so that is just an opinion, and it's really not a valid reason to choose one over the other. You need to make your own conclusions, and you could even discuss it with your patient. You could say, look, we have these two options, and make a decision there. The bottom line, to answer your question, is that either are valid medical control options. If you want my personal opinion would be diltiazem is a better drug for to use as a calcium channel blocker. But that's my personal opinion. Okay. Well, hopefully that gives you a sense of how these drugs work and some kind of a rational basis for choosing one over the other. I hope that answers your question. If it does, great. If it doesn't, please let me know, and I will follow up. I hope this was a helpful video, and I'll see you guys out there in the ERs and on the streets.